Hello everybody and welcome to the Thursday edition of Video Clips, and today I want to talk about the HPV vaccine. I've been doing a lot of research on this and related issues because I'm teaching a course on this topic right now, and it's one of these things where the research and writing that I do for this, I can't do it before bedtime because it just makes me too angry. I have been writing specifically for years about the significant risks associated with the HPV vaccine, and I've been questioning its efficacy really since it was introduced. A new analysis confirms my concerns. Researchers report that methodological problems and statistical limitations for trials in which the vaccine was supposedly tested for safety and efficacy were serious. So serious, in fact, that it was impossible to know whether the vaccine actually could prevent cervical cancer at the time of approval, and there are still no data available showing that the vaccine has the potential to be effective. The researchers identified 12 randomized controlled trials that included Cervarix and Gardasil, the two brand names for HPV vaccine. And what I've done here is summarize some of the issues in this article. I'll post it in the library sometime this week, but I'll just go through the points one by one. So the first thing is, and many people don't know this, the trials were not designed to determine if the vaccine prevents cervical cancer. Now that's a major problem because the selling point was for the vaccine was that it would reduce the risk of cervical cancer, but the trials were not designed to show that outcome. The efficacy was most likely significantly overstated. The screening of the subjects in the trials was more frequent, every 6 to 12 months, instead of the 36-month interval actually used in practice. Clinically inappropriate outcomes were used, such as cervical intraepithelial neoplasia, or CIN, grades 1 and 2. CIN and CIN1 and 2, often resolve without any intervention over time. Despite this, these were included in composite and distant surrogate outcomes. Another issue was the time period in the trials, which was shorter than the time it takes for CIN1 and 2 to resolve on their own. So essentially what they were doing was looking at lesions that generally go away on their own and don't cause problems. So even assuming that the vaccine is effective for low-grade lesions that often spontaneously resolve, which makes you wonder why would you want to do something about that, this doesn't mean that the vaccine would be effective for higher-grade lesions, which actually can progress to cervical cancer. There are no data at this time concluding that the vaccine is effective for CIN3 and adenocarcinoma in situ, or AIS, which are serious risk factors for cervical cancer and death from cervical cancer. I suspect, and we'll never know, that one of the reasons why these were not included was because it was not sure that they would get the outcome that they wanted. One study did look at the reduction in CIN3 regardless of HPV type. The study showed a reduction in risk, but there were study limitations that really would make you question the efficacy. Again, the study design was not appropriate for the thing being evaluated. There was underrepresentation in the unvaccinated control group, shorter follow-up time for women born in the time period 1995 to 96. There was absolutely no basis for any claim that there was herd protection for unvaccinated women, and there was no confounding for changes or reduction in sexual activity and how this might have resulted in decreased incidence of CIN incidence independent of the vaccine. Now, why is this important? Well, you grow up and you become a mature person and get married and you don't have sex with as many partners and your risk for these types of things goes down, and that wasn't included in the trials. So very sloppily done. Hard to believe that this much sloppiness could have been unintentional. It seems intentional to me. 5 trials combined cervical disease and persistent HPV infection, and 4 combined cervical disease and genital warts, which inflated study results. Remember what we're trying to do. They're measuring everything but does it reduce the risk of cervical cancer. So the reality is the trials didn't really evaluate the efficacy of the vaccine on the precancerous lesions that matter in a methodologically appropriate way. And, leading to that, the primary outcomes measured were irrelevant. The primary outcome measured was incident infection with HPV 16 and 18. This is an irrelevant surrogate marker since such infections rarely progress to cervical cancer. In spite of the fact that there is no agreement on the definition of persistent infection, one Gardasil trial, the researchers just decided to define it as 12 months, even though there's no basis for it, and measured it as an outcome. Efficacy in girls 9 to 13 years of age was estimated using immune response levels rather than clinical outcomes. At this time, nobody knows the level of antibody titers constituting protection against precursor lesions or cervical cancer. So the outcomes measured were simply irrelevant. Next thing, the trial population was different than the target population. While the initial target population was and remains children, the youngest trial participants were age 15, and the selection criteria didn't restrict the participants to only sexually naive girls. Further evidence that the trial population didn't resemble the target, which recently was expanded to women up to the age of 45, 7 trials excluded women with more than 4 to 6 sexual partners, 5 excluded women who had previously had an abnormal Pap test, and 3 excluded women who had a previous colposcopy, which is the procedure done in response to the abnormal Pap. These restrictions would make the vaccine appear to be more effective than it would be in the general population, which would certainly include at-risk women. The follow-up period was too short to determine the effect of the vaccine on meaningful outcomes. Cervical cancer takes at least 10 years to develop, but the average period of follow-up was 6 years or fewer. At this time, there are no data on how long protection lasts, and the researchers state, and others have expressed this same concern, I've spoken about this before on this channel, that protection will not extend to the time of peak exposure when you vaccinate girls at the age of 9 to 11, for example, which is the original target market. Another concern, the trials raised the possibility that HPV strain substitution can be an issue. There was a statistically significant increased risk of infection with HPV type 51. In other words, while potentially but not definitively protecting against some HPV types, the risk of infection with others may be increased. Viruses are very smart, and they mutate and they do whatever they have to do to survive. So this has been shown to be a risk factor, by the way, with other vaccines such as pneumococcal vaccines. So the idea of strain substitution is not a new one, and it has been shown to be a factor with other vaccines. The next thing, the epidemiology of HPV is different in different areas of the world, yet the study results were never broken down by country, study site, or for each outcome. Again, hard to believe that this level of sloppiness. You could, it's hard to believe that there would be any sloppiness in what are supposed to be experienced researchers, but there's no rigorous supervision of clinical trials or demand that the data be reliable, so I guess this isn't surprising. All right, next thing, HPV testing is not reliable. DNA testing for particular HPV types to determine ongoing or previous infection is not reliable, which makes HPV infection a poor surrogate marker for cervical cancer. Only 50 to 70% of HPV infections result in detectable responses, and those who test positive can later revert to a negative state. Women who test negative may actually have had exposure, and latent infection is sometimes not detected. No one knows how frequently latent infection occurs, how long it lasts, what causes reactivation, and the percentage of patients who go on to develop cervical cancer after a period of latency. So we may really be looking at the wrong marker, and that brings me to the next point. HPV may not be a marker for cancer after all. HPV infection is common. The lifetime risk of exposure is 79%. In other words, almost 80% of the population has been exposed to this virus at some point in time. Most infections are transient, 67% clear without intervention in 1 year, and probably more than that because of the Pap testing, generally testing is every 3 years, which is a limitation that I pointed out earlier. It's estimated that 10% of women who do not have CIN have HPV, but little is known about how or even if HPV infection and precursor lesions progress to cervical cancer. We really don't know that HPV causes cervical cancer. We know it can't do it by itself, but we don't know to what extent it's even a risk factor. So a fair question to ask, and the researchers deal with this, can future research fix this? Can we resolve the uncertainties? The researchers note that there is no research currently being conducted that would resolve these issues. None of the studies are ideal. They're small, short duration, and not looking at the primary risk factor for cervical cancer, which is CIN3. So nobody has done a study to determine if women who get this vaccine over a long period of time develop less cervical cancer than women who don't. Here is my comment in response to some of the data the researchers report. I've always said this: the vaccine seems to be a solution in search of a problem. The researchers concluded that in the UK, cervical cancer screening is estimated to prevent over 80% of cervical cancers. An analysis of cost effectiveness in Australia concluded that the vaccine is not cost effective in areas in which cervical cancer screening is well established. There is no way to know how many cases of cervical cancer supposedly prevented by the vaccine would have been detected by cervical cancer screening, which is significantly less expensive. And what we should be doing, and this infuriates me, it wasn't discussed in this particular article, but we should, because cervical cancer screening is so cheap, we should be exporting that to other countries, and particularly developing countries, instead of pushing this god-awful vaccine. My final comment, and this has nothing to do with what was in the article that the researchers wrote, more people should know about this. In the UK, where censorship is not as prevalent as here, this study is reported in several mainstream UK publications. In places like the United States, where anybody discussing data that refutes the rabid belief in vaccines is ridiculed or censored, not so much. So more people should know about this. So I have serious issues with a lot of what goes on with these vaccines. I think this one is probably, it's got to be at the top of the useless and harmful category. And Cochrane collaboration researchers have arrived at the same conclusion, the ones who still remain independent. So it's all risk, it's no benefit, and there's no possible benefit because it isn't measuring the thing that should be measured, which is over an extended period of time. Girls 9 to 11 years old don't develop cervical cancer, but women in their 20s, 30s, 40s, 50s do. So the only way to know is to follow these women, these girls, for a long period of time and see who does and who does not develop cervical cancer. That research has never been done. It's not scheduled to be done. The FDA isn't demanding it. The European Medicines Agency isn't demanding it. In the meantime, this vaccine has been taken off the schedule in Japan, and the government has set up clinics to address injured girls and adults. So there are some countries that are recognizing that this may have been a very, very bad idea all along. Well, as usual, pass this on to anybody who you think would enjoy watching it, and I will be back to you with more news next week.